Okay, this is the final panel for this meeting, and in some ways the most important, because they're going to tell us how we're going to pay for all the things we've been discussing. We started with policy, which is actually in part the distribution of resources, and we're going to end with that as well. We have a really nice panel. We had an additional pediatrician on the panel who unfortunately couldn't make it, but Suzanne Fields has agreed to step in and fill in for some of that, to think about how we do funding for complex care and the kinds of care that we've been describing. So Susan, I'll let you take it.
Well, good afternoon. You all in the room will now know the secret location of the money tree. All right, so don't let anybody else in. I'm very pleased to be able to facilitate this panel with Catherine and Chris, and I'll also be talking with you a bit about behavioral health as well as a discussant. So given time, I'll go ahead and let's move on to Catherine providing context for us.
I don't have my presentation. Okay. Thank you very much. It's an honor and privilege to be here. I will go ahead and start with some brief introductions of myself as we're getting the slides up. My name is Catherine Anderson. I am Vice President of State Programs for United Healthcare, Community and State. And my responsibility is helping states structure programs. And so I spend most of my time in the policy realm, sometimes in the political realm as need be, to find solutions to complex issues, particularly around funding in the Medicaid world. And I will also give you a brief overview of United as we're pulling the slides up. So we are, depending on the day or the numbers or how you look at it, some say we're the largest Medicaid HMO currently in the United States. Thank you very much. And we operate in 24 states plus the District of Columbia. Well, soon to be 25 states in a few short weeks with the addition of the state of Iowa in their new program. We serve more than 5 million Medicaid beneficiaries today. The majority of the individuals that we serve in our contracts are actually children. Most of those are TANF kids, but a growing percentage of the population we serve are complex populations that run the gamut from birth to death. We operate specialty programs for children with special health care needs in Arizona, Texas, and Michigan. And we happen to be a part of a very complex organization, United Health Group. I am in the part of the organization dedicated to serving Medicaid beneficiaries. I think all of us in the room have a shared agenda to get to improved care, but for some reason it's really, really hard, particularly as we think about complex populations. And there are many things that are directly impacting children with special health care needs that I'll touch on a bit, but largely they're organized around these 4 bullets of payment, delivery, integration of benefits, and transition to managed care. More and more frequently, we are seeing significant shifts in states moving complex populations from fee-for-service into managed care. And I've been doing this, I've been with United for 18 years now, and I've been having these conversations with states for many years, and there were lots of populations, even as recently as 5 years ago, that people said they'll never be in managed care. The reality is that states are rushing to put individuals that otherwise people would have said couldn't be in managed care into managed care, which brings its own unique challenges. So clearly there's a goal of person, family-centered approach to services. We feel very strongly about that, as do we feel strongly about a shared goal of having holistic, person-centered benefit design. Along with that, ideally, we'd love for it to be easy to navigate. However, we know that even from within our organization or in the populations we serve in those states, it's not easy to navigate services, particularly as we increase in the complexity of the populations we serve. We know that the environment is highly fragmented. We know that there are layers of programs and that those programs have been designed over time. You start with one waiver, states add another waiver and another waiver. And unfortunately, what we see then is that the benefit designs for many of those waivers are an inch wide, which then creates more fragmentation in the system and creates challenges for people who are only eligible for a program that's this wide when really their needs are this wide. And so there's real significant complexity just in program design alone, and then you layer on the challenges of managed care in general. We also know that there's pretty significant limitations on the availability of meaningful data. States are becoming much smarter as are providers and payers in terms of having data, but because services are so highly fragmented, often the data actually sits in multiple repositories, and that data is actually not integrated. And in many instances, it's virtually impossible for us to get to all of the data to make it meaningful, integrated model to really see what's happening, how are services being delivered, what's effective, et cetera. So I'm sure all of you know all of this information, but I think it's always helpful to look at it in writing from a complexity of payment streams. As I stated, our part of the company within United Health Group focuses on Medicaid. There's lots of stuff even in Medicaid that when you look at state plan benefits as compared to waiver benefits, as compared to TEFRA programs, buy-in programs, Medicaid isn't just Medicaid. The old adage, if you've seen one Medicaid program, you've seen one Medicaid program, and I would say even within an individual Medicaid program, when you look down to the beneficiary level, it is unique based on populations. And then we layer on the right-hand side a whole bunch of other funding streams that may be paying for a portion of the medical care and more likely paying for social determinants or social supports that have direct impact on the efficacy of the medical care. So this is an interesting slide, but I'm not going to spend too much time on it other than to say that there's a pretty significant chunk of services being paid for by Medicaid. I don't expect you to be able to see the percentage, but 36% is being publicly funded as compared to 52% private funding. So there still is a really big variation actually between public and private, and we know that there's also then folks that fall into the both publicly and privately funded, which then layers on complexity as well. The good news, and this is not specific to children with special health care needs, but we know it's a subset of those children, the number of uninsured children dropped dramatically between 2013 and 2014 because of the implementation of the Accountable Care Act, which is good because it created coverage for kids who likely weren't covered, or their families, more importantly, that weren't covered prior to the implementation. We also know that the income breakdown is a bit of a challenge for children with special health care needs and their families. And I think what's interesting, while 29% of the population is above 400% FPL, that means the vast majority of these children and their families actually fall below 400% FPL, which puts them in a subsidized category and puts them in a category where there's a variety of programs for which they might be eligible. And again, it's not just Medicaid, it's everything else. It could be housing, it could be access to food, could be education supports, could be transportation, and all of that comes into play when we look at where is the funding actually coming from. Our data shows us, and this is across all Medicaid beneficiaries, so it's not broken down for this population, but I would say it's probably higher than this for this population, that 40% of the medical costs are actually driven by non-medical things. And so when we look at the breakdown of income, it's really important for us to understand all the social programs that an individual or their family might be eligible for. So this is on the left-hand side of the screen is total state expenditures. So this would be any money coming into the state. Could include funds that are not general funds. The right-hand side is just purely general funds. And you can see where Medicaid is, sits at 15.6% of the state-only funds. And I can tell you states are freaking out just by that number alone. That it's getting worse, though, because that piece of the pie is growing substantially. This is the estimated expenditures for fiscal year 2015. The disappointing thing is that you see one going down pretty dramatically, and those are social programs, and one going up rather dramatically, and that is Medicaid. This is the reason that states are rushing to manage care for their complex populations. And specifically, we're seeing new trends in how states are looking about it. It used to be that states would say, we're going to bring in the moms and kids, that easy TANF population, into managed care first. Then, once we do that really well, we'll think about moving more populations in, and we'll do the really complex ones last. Well, what we're seeing, because of these budgetary pressures, is actually states are moving. States who haven't done managed care are bringing all of them in at once. Like Iowa is an example of that everybody's coming in January 1st. Or we're seeing states like Oklahoma or Arkansas that are looking at the complex population first before looking at any other population in managed care. And part of it has to do with the fact that the spending spike is really unsustainable. This is data that I'm sure all of you have seen in one shape or another. It comes in lots of different graphs, but this shows that and this again speaks to the importance why states are looking at it, the percentage of individuals who are eligible for Medicaid as compared to their spend. So children with special health care needs are lumped in, unfortunately, in the aged and disabled data in this graph, but I think it's meaningful because, again, they represent a really small percentage of the individuals who are eligible for Medicaid, but they're driving significant amounts of the cost. And this would be consistent with data even in our membership. When I mentioned we serve more than 5 million individuals, majority of kids, and they're these non-disabled kids who are relatively uncomplicated and relatively inexpensive as compared to the aged and disabled. The other thing that's important, although this data is not entirely reflective of the impact of the Medicaid expansion lives, that adult column, we would say, really hasn't changed substantially over time. There are some impact on the expansion lives from those states that chose to bring additional adults into their Medicaid program. Their costs are slightly higher than traditional adults, but still the aged and disabled population outspend the rest of the populations. For a long time, we've heard states talk about how complicated it's going to be when all the baby boomers come into the system. And it is complicated when all the baby boomers hit the system. But what's more complicated is actually the number of individuals who are becoming eligible for Medicaid because of disabilities. Those numbers are, on a percentage basis, outpacing the baby boomers' entrance into Medicaid pretty substantially. And I think that many policymakers weren't as prepared for thinking about that. They were thinking more about the graying of America rather than the number of people who are becoming eligible for Medicaid through a disability. And my clock's not working, so I hope someone's paying some attention. Okay, good. We know that there's lots of unmet need. This is a representation of the children who are on waivers. I will say that this isn't necessarily reflective of children who are actually covered in managed care because in an 1115 waiver, this is only representative of 1915C waivers. We also know that there are a couple states, my panelist is from one of them, that has a really big waiting list for some kids that's really pretty impactful in accessing services. In fact, I was with members of our Texas team recently, and they were talking about their own experience. Two of them are mothers of children with special health care needs, and their own experience for how many years those kids sit on the waiting list before they get access to services, which is pretty remarkable and puts a pretty significant strain on the system as well as their families for certain. There's lots of things happening in the reform world. First and foremost, virtually every state that I talk to wants to address payment reform. And there is a broad spectrum of what that means in a state. In any given week, I can have someone say, well, we're going to implement ACOs. And when you actually talk to them, what they mean is completely different one state to another. And appreciating what an ACO does. We do know that most states want to move to some sort of pay for performance, and it is at all levels of the system. So more and more of our contracts are tied specifically to performance, and there is a very significant expectation that we, on behalf of the state, bring more and more of our contracted providers into some sort of pay for performance model. In fact, we have a couple states that have put really significant thresholds out there for us in very short periods of time to have 75–80% of our providers in network in some sort of meaningful incentive model. There currently is some discretion in what that means to be in some sort of pay-for-performance model. It's not all capitation ACOs. There is a spectrum, which we think is most appropriate. But what's most concerning to me in terms of these complex populations, regardless of children or adults, is that I think a lot of providers aren't necessarily prepared for what it means to care for the population. And so when we're tying more and more of their payment to performance, and yet they're not necessarily completely prepared to care for them, we may have a situation where the pay for performance actually has negative consequences, which we want to try to avoid. And it's really a very delicate balance, again, when states are putting out performance guarantees for us to have a vast majority of percentage of our providers in some sort of incented arrangement. On the right-hand side at the top, this speaks to most states, the majority of states have or are moving to manage long-term services and supports. Again, it used to be that there were just a handful of these states, and they're moving very rapidly. It also was quite common to take more than 5 years for a state to actually move to a managed long-term service and support managed care model. But in fact, many states are doing it in less than 12 months. And so very rapid cycle. Some of that has to do with the fact that CMS has provided additional guidance. Some of it is the fact that there's a roadmap, other states have done it, that they can follow, and some of it's just simply budgetary pressures that they're responding to. The other thing that I think is pretty meaningful to this population in particular is that there are more and more states that are moving to integrated behavioral and physical health. And we're seeing that in a variety of ways, either in specialized contracts where people who have significant behavioral health issues are in a different managed care plan, or we're seeing more and more either procure with behavioral health as part of the contract or just add behavioral health in during a contract term. This speaks to the growing interest in managed care. You can see this, the color is the percentage of population that's covered by Medicaid managed care. The darkest blue are those states with very high percentages of individuals who are in. Interestingly enough, if you look at the gray, which is where there is no Medicaid managed care as of when this map was drawn, those states are very few and far between. And from our perspective, they're some of the most challenging states to think about how do you manage populations, specifically complex populations, because they happen to be rural or frontier, and I'm a native of one of them. So I can tell you it's really hard in Wyoming to find specialty providers. So I want to talk a little bit about our considerations as we think about how we run these health plans and what's asked of us. We believe the best approach is to have almost a health plan within a health plan that's specifically designed for complex populations. We can't very well manage all kids regardless of their needs in the same way, and so by creating a team within the team, we've been more successful in being able to really meet the needs of the children we serve. We also know there has to be pretty significant expertise. If you have a health plan operator who has historically just managed commercial insurance, they probably have no idea how to manage complex populations. And so we are spending a lot of time looking for the right staff to make sure that we have good expertise within this plan. We also know that there have to be advisors that are really important to the health plan. So we've developed a team of experts that are focused on unique populations in order to provide expertise to our plan leadership as we continue to grow the expertise throughout the organization. Benefits are really super important. And that should be a no-brainer. But there's parts of why benefits are important that I think states continue to miss a bit on. Within managed care, there is flexibility for benefits. We have the ability to access benefits in ways that you can't outside of managed care very easily, which is the good part. And states expect us with specialty populations to really use that flexibility wisely. The challenge, however, is the payment doesn't always follow that flexibility. And so while we may think it's important, for instance, to build a fence around a yard to provide a safe play area, it's really hard to encounter that fence around the yard, and therefore those expenses that went out the door, which we know improved medical spend over time, we actually can't be reimbursed for unless the states are really thoughtful in their program design. So it has to go beyond flexibility to looking at what the payment terms have to be. The other thing that I think many managed care organizations who don't have experience in these populations understand that that parents will go anywhere for services, and that oftentimes services aren't, there's one specialist who does this very unique thing, and that flies in the face of a traditional network model. It gets network folks really very anxious, and they want to just say, but there's a pediatrician just down the street. Why can't that pediatrician just do this care? And so it's really important from a health plan perspective to make sure that there is an appreciation for the complexity of network, that how you manage out-of-network benefits, how do you make sure that you can access services nationally. We run one of these, a plan with several children with special health care needs in Hawaii, and those kids are on planes lots. And we have to be comfortable with that in order to make it work. I touched on the financing. The other thing that I would say that's really important is that the savings assumption should be really carefully determined. So this is one of those problems when states see the amount of money being spent on a complex population, there is an assumption in many legislatures that there's a lot of money that can be saved. And so one of the things that we caution states is that certainly rates need to be actuarially sound and viable, and there should be transparency in their development, but there also has to be reasonableness in the savings assumptions that are applied, so that there isn't an assumption that you put managed care in and suddenly half of the dollars are going to go away because we're just going to do a great job of taking away services. We know complex populations, particularly children with special health care needs, often don't have significant savings tied to them. There are opportunities to reduce fragmentation. There are opportunities to improve outcomes and quality. That to us is more important than thinking about them in terms of large savings. I'm going to move ahead just quickly. We have what we call essential elements. These are the things that we talk to our states about as they design their programs to make sure to make sure that their programs are designed well and meet the needs of the population. So first and foremost, flexibility is important. And while I said that we automatically have a certain degree of flexibility to do what's right to meet the needs of our members and their families, there's a lot that states can do to make sure that that flexibility is ingrained in the program design. We also think that it's very important to make sure that network adequacy requirements reflect the needs of the population, that it just simply can't be a geo-access report or that providers are available in 30 minutes or 30 miles, that when we start talking about complex populations, we have to be very mindful of the fact that network adequacy looks very different for subsets of the population, particularly complex populations like children with special health care needs. We also think that One of the biggest misses in states today is on the innovations bullet. There are still many states that don't allow for the active use of telemedicine, which has become a bit of a battle in many states as to when we can use telemedicine. And we know that many things we can do very well, that are done very well in commercial settings in individuals' homes. And not just in providers' offices. And so, and that continues to be a significant barrier for the use of technology to solve some of the access issues. The other thing that we would say is really important to stakeholder engagement is very important. And this isn't just at the state level. I think most states, mainly in some instances because CMS has told them they have to, they are doing really good stakeholder engagement, but stakeholder engagement has to trickle down to the health plans, and health plans should be maintaining active member advisory boards that are a cross-section, either a cross-section of all the individuals that they serve, or having unique subset boards that are focused on specific populations. For instance, at a national level, we have a National Advisory Board that's only focused on complex populations, and they provide us guidance, and that sort of model should be translated down to the health plan level. There's also care coordination, which is probably one of the most complex things, and I'm giving myself a minute to talk about it. But one of the things that we know happens is that there's a lot of care management that happens around some of these kids. And there's a care manager with lots of different programs all trying to work for that child and that family. And we know everybody's intentions are fabulous. So it's really, we believe, our responsibility as a managed care organization to try to tie the pieces together, not to supplant really good care coordination that's already happening, either in the physician's office or some other setting. So our job should be doing assessments and making sure that there is comprehensive care coordination, who's doing it, how do we put the pieces together, and filling the gaps in as necessary. We also think that a big miss that happens a lot of times for health plans who've not had the experience in managing complex populations, by the way, we've been doing it for 30 years, is that they don't necessarily understand how to use community-based services very well. That there's an over-medicalized approach in many instances, and there's a lack of appreciation for the fact that many services are done really, really well in the community today. But they're done, again, on an individual program level or at an individual waiver level, and it's not all tied together. And so we think that one of the best things a state can do and managed care organizations can do is to make sure that we know how to put the pieces together and how to leverage what's being done really well in the community. And in many instances, invest in those things that are being done really well in the community so that those programs can grow and provide additional supports to additional children in a meaningful way. So with that, I'm gonna close up. I think we're gonna make the slides available, but I will be around for questions. So.
There we go. Good afternoon. My name is Chris Bourne, and I'm the president of Texas Children's Health Plan in Houston, Texas. And I wanted to give my great thanks to Ed and the Lucille Packard Foundation for giving me a very nice invitation to this very, very important symposium. I sit here in awe and I listen to what you all are presenting. And as an administrator for Children's HMO, all I think about is how to implement the research and the learnings that you are in the process of publishing in the past or publishing in the future. Of course, I read everything about children with medical complexity, so Dr. Berry, Dr. Antonelli, Jeannie McAllister, Carl Cooley, though I don't all know them in person, I feel like I know them based on their research. I internalize it and I apply it to a particular population. Texas Children's is a very large pediatric system. It has a 600-bed hospital. Half of it is NICU and cardiovascular ICUs and progressive care units, intensive care units. It is affiliated with Baylor College of Medicine, has one of the largest pediatric residency programs in the United States. I can't tell you how many luminaries the hospital has. It's too large to count anymore. And they have an expansive program of a network of primary care physicians, just pediatricians, a network of OBGYNs. It is in the maternity market. It does everything, and it does everything great. But the health plan, which is a licensed HMO, I'm trying to think how I advance this. The clicker, the secret clicker. So Texas Children's Health Plan is a licensed HMO. We've been doing Medicaid and CHIP since 2001 and 2002. We entered the game late on the Medicaid program, but over the last 15 years, we now are responsible for almost 48% of the Medicaid and CHIP population in that 20-county service area. So we've been, as Catherine said, right now, the majority of the population that's in Medicaid managed care, the TANF population, pregnant women, and then the CHIP program is a separately administered program. We have 1,200 primary care physicians, 3,000 specialists, 77 hospitals, and contrary to what you normally think, if I can keep a child in a community setting, that's economically better for Texas Children's Health Plan than it is for Texas Children's Hospital. So I'm not trying to cram more patients into the hospital. What I'm trying to do is to keep them in the community, right place, right care, right time, right cost. We are also in the process of developing captive big box medical homes, and I'll explain what those are in just a little bit. But we are talking about financial considerations, and I feel obligated to show you some numbers. Is that okay? So Texas Children's Health Plan over the last 9 years has used one common platform for managing both our Medicaid and CHIP population. And when I did this study in 2014, what I was doing is I was going back 5 full years and looking at a population that was continuously enrolled in our health plan for those 5 years. And when our business analytics guys came back and said, Chris, there's only 14,000 people who've remained consistently insured in your health plan for 5 years, I go, but there's 2 million records in my database. Where'd they all go? And he goes, well, they fall off of Medicaid. Medicaid only covers for 6 months in Texas. So on average, I only have a Medicaid life for 8 months out of the year. They fall off for 4 months. Somehow they get back in. They get an emergency Medicaid. They show up at the emergency room. Bingo, I've got them back again. So it's difficult to figure out what you're doing with a Medicaid population unless it's consistently enrolled. So what I did is I allowed for 1 month of lapse time, and I ended up with 57,000 members who were continuously enrolled, put them into deciles by their total cost, and was able to give you an identification of what the cost was on average for the 5,750 kids who were in the top 10%, and then what it was like in each decile going down. And consistent with what you've read about and seen in the data, the top 10% are driving, in my case, 57.2% of the cost for those who are consistently enrolled in my health plan. And when you drop down to the 20%, it's even more. Highly concentrated medical costs. I like that row in the 0 to 10%. I'm spending $4.50 PMPM. I don't know what they're consuming for $4.50 per member per month, but I've got 5,700 of them, and they help balance out the whole population that I'm managing in this analysis. One of the things I wanted to show you is what that graph looks like over time. And you can see that anybody who's in the 90% or low, it's consistent. Okay, I may have some outliers in there, but it's relatively consistent. Only when you start in the top 10% of that population of continuously enrolled is you start seeing some variation. And I think when, we were talking yesterday about the identification of children with medical complexity, I know where to focus, right? I've got all the claims data. I know what they're consuming. I'm going after those kids with my care management program. Looking at it a different way, what we did is we were able to look at the consumption of healthcare by year. And if we see on a longevity, 4 years, if we see a spike and then it levels out where it's episodic, right? They went in and had a particular procedure. It was an expensive procedure that put them in the top 20%, but then it leveled out. You can see that cost is relatively flat. It's the chronic conditions that we have, the long-term cancer, trauma victims, spina bifida. It's all those conditions that last a long time that need the most help, but there's the most variation. I'm not going to go over my box plots. One of the things in financing this population and the cost is the high degree of variability can lead to some rather startling outcomes from an expense perspective. So if I started with that 2009 cost and I ran it up by what it was in the subsequent years, I might have lost $5 million in the first year, $3.8 million in the second year, and $5.3 million in the third year. So those types of big swings in the cost of care is something that I have to consider. And the only way that I can make that work is because I have the 52,000 children who aren't consuming as much health care to balance that out. Plus, I have an additional 3,000 or 300,000 children in my population that's coming in and out of my Medicaid system. So let's talk about what's going on in the future. So Texas Children's Health Plan advocated for the inclusion of a specific population of Medicaid-eligible children who qualify for Medicaid as a result of a disability. Now, when you talked about the definitions, how do you categorize children with medical complexity? I didn't have to worry about that because the Social Security Administration did it for me. And it just so happened in Texas, they were all in the fee-for-service system. So they were ripe for the picking as far as putting in a managed care delivery system. I told Catherine that the representative for United in Texas and I were having a big fight, and what she wanted to do is she wanted to take the children with medical complexity in the SSI program, push it up with the adult disabled population they had, and call it a day. Where I thought children with medical complexity, core competency of Texas Children's, I thought we needed to build something surrounding those children that make more sense and can address the medical concerns and the behavioral concerns of that particular population. So they're moving into Medicaid managed care delivery systems on November 1st, 2016. We'll be responsible for all the medical, behavioral, pharmacy, and the long-term support services that go along with that program, like private duty nursing, personal care services, all the durable medical equipment, adjunctive services, wheelchair modifications to the home to keep them there. And so it's a whole new scope of services that we'll be providing, but it's going to give us new visibility into how the healthcare system works, where we are only focused maybe on inpatient care, subspecialty care, and primary care. The estimated premium revenue with a 50% market share is $600 to $700 million. Now, I'll give you something. So Texas Children's, all of the care delivery system is $1.8 billion. $1.8 billion. Texas Children's Health Plan with this population is going to be $1.8 billion. Do you see a tipping point happening? So 50% of the system's revenues are now capitated. Is that going to change transformationally the way that we provide care for this population? You better believe it. It is going like a flu virus through the Texas Children's Organization of how we think about transition medicine, complex care, technology-dependent children. Everybody's thinking about how we can do things differently to make the lives better for the children we serve. This is the map of how they divided Texas up. In Harris, where I work, it's that kind of orangey color. I am also in that green color above that, and I did a service area expansion, so I'm in the Northeast Medicaid Rural Service Area that flops over the top of Dallas and Fort Worth. That's interesting, isn't it? The other thing that's important about this is Dallas Children's bid on Dallas and got it. Cook Children's in Fort Worth bid on this SSI product and got it. Driscoll Children's in Corpus Christi bid on that and got it for Nueces and in the Valley. You're seeing more children's hospitals getting into the business of managing this complex children's population, and the rest of the state was divided between Superior, Centene, United, and Amerigroup. Okay? And so I'm competing with United in 3 of the service areas and Amerigroup as a 3rd in the Harris service area. This may be a little hard to see, but this is the projection of the membership in our service area. It's almost 65,000. What I think my market share will be and what I expect my cost to be by whether it's inpatient, it's outpatient, it's pharmacy, it breaks it all out. I'm sorry you can't see that, but a total is $667 million in just medical expense. But probably the most significant thing is that other line is huge. It's almost $442 million of services that are outside of the hospital system that is dealing with home care and durable medical equipment, private duty nursing, personal care assistance. That's where the expense is, right? Here's another thing. So being part of a system, I know how much these children are utilizing Texas Children's Hospital. So in 2013, $193 million was that Texas Children's provided to this population at a, wait for it, a loss of $7.5 million. Okay, so every SSI admission at Texas Children's lost money. Gets even worse. Look what happens on the outpatient side. Same children consuming outpatient care, $34 million in losses. Okay? This is a problem worth fixing. So what are we doing? Risk mitigation, this is the finance part. Law of large numbers. You know, the few don't determine whether I'm going to have a loss or not. Reinsurance, risk corridors, risk adjustment are all perfect. Network design. You know, it was mentioned that 47% of the physicians don't want to serve medically complex children, or it might have been the inverse of that, I'm not sure. We know within our network of 1,200 primary care physicians which doctors want to serve this population. And so what we're doing in the market is we're identifying those physicians, we're supporting them in their patient-centered medical home NCQA licensure, we're paying them more money, we're embedding care management in their offices. It's going to be an important thing to generate a cohort of those primary care physicians with a significant interest in that organization. The high-functioning medical management, I have to hire 200 medical management FTEs by November of 2016 to manage the medical complexity. They have to be in the home of these patients doing assessments and individualized care plans. Those care plans will be on a portal, both a member portal and a provider portal for distribution throughout our system. And we're looking at reducing utilization because maybe reducing utilization will actually be a gain in our system. We have business plans, so the children with medical complexity, you'll notice that that design there, that's Ed Wagner's. It's used with permission. So we built into our model for taking care of these children with medical complexity, Ed Wagner's. So we think about behavioral health and medical and community and family involvement. We're developing a really super clinic for complex medical children run by Carl Tapia. You can see that they're going from managing right now 662 patients with medical complexity. They're going to be managing 3,619. They're going to go from 6 exam rooms to 25 exam rooms. They're going to go from 80 FTEs, 8.2 FTEs up to 80 FTEs. We're making investments in our complex clinics to serve this population better. And then, of course, we're developing captive medical homes. These are medical homes. They're big. They're 50,000 square feet. They do obstetrics, pediatrics, integrated behavioral health, integrated clinical pharmacy, vision, dental. It serves, the fee-for-service system is blown up in this thing. I blew up fee-for-service. It only serves Texas Children's Health Plan members. And it's open from 7 to 11. It's open on Saturdays and Sundays. They get patient registries. They're on the same Epic EMR system. The results of what I'm getting out of this patient-centered medical home is phenomenal because it's integrated obstetrics and pediatrics, and if I can save on NICU costs, I've paid for the whole thing. Okay? And I think that's it.
I do have a PowerPoint. Thank you. Hello. While my PowerPoint is coming up, I also want to thank you, Ed and others, for the invitation. My involvement came about because I'm actually hosting a meeting on tiered care management approaches in managed care specific to behavioral health. I'm with the University of Maryland. We are the location for the National Technical Assistance Center related to the financing and service delivery of children's behavioral health. We lead a group of 12 other national organizations with various expertise in behavioral health, including Family Voice, Youth Voice, Workforce Development, and again, the financing and the kind of delivery platforms that we see kind of specific to behavioral health. So I appreciate being able to participate in this meeting. And certainly also, my comments are going to go back to a lot of the themes from today, but also certainly from yesterday as we think more about the social complexities of the children that we serve and the families that we are here to support as they support their children to navigate. We mentioned yesterday the high costs of behavioral health. This was actually cited, I believe, by 2 different speakers yesterday. What I had wanted to turn to was from my colleagues at the Center for Healthcare Strategies, which is a specific look at behavioral health. So this is a specific lens about children in Medicaid who have behavioral health needs. Now, of course, we're talking about both public and private insurance throughout this. We wish this type of robust data was available privately. We do have some initial findings, say, from MACPAC and other studies looking at private insurance, but really what we know about behavioral health and the robust data we can turn to is often just specific to Medicaid. And as we think about this, what I would like to be able to offer up to all of you as my colleagues in the room is that we have specific lessons learned from behavioral health that we can bring into our other strategies as we move towards better integration with physical health care, mental health, and I would say also substance use disorder care. Now, all of these lessons that we'll be talking about unfortunately come from our bifurcated financing system. These are lessons that we've gotten as there have been separation in the money and in financing of behavioral health. And as we move towards integration at a dollar level, and again, that we need to separate that from integration at a practice level, as we move towards integration at the dollar level, it's really important for us to understand what have been the lessons in behavioral health, how do we preserve those, but what of those lessons can we use as a launching pad for a lot of what's being talked about here? So for example, in behavioral health Medicaid, there's a dozen states in the country who are covering families with lived experience to serve in professional roles and be Medicaid reimbursed. And so that was something we've heard repeatedly here. How come that's not available for us on the medical side? But we do have that lesson learned on the behavioral health side. So going back to this data, we see that a very small percentage of children who have any type of behavioral health need are driving a high percentage of the Medicaid spend. Now, of course, as we look at this, we do have to keep in mind that this is identifying children who have a claim. So we do have the challenge of what is the prevalence of a behavioral health condition that is not being diagnosed, that's not resulting in a service. So we can anticipate that the need is much greater. But again, this begins to help us understand what's happening. And so what we see as we look at this data is that it is not necessarily the physical health spend driving Medicaid costs, but it is the behavioral health spend that is driving our Medicaid costs. And as we look at the different populations of children covered in Medicaid, we see those variations moving forward towards the most disabled population, of course, having the highest cost drivers, but children in foster care, children involved in child welfare, having very similar cost panels to children that have the most disabling conditions. Here is some data looking at mean expenditures, and again, this reinforces that it is behavioral health driving the costs in the Medicaid system. As you look at children who have their physical health costs, as you look at their behavioral health costs, and as you look at their overall costs. And these are, excuse me, just a couple of slides I've taken from this very comprehensive work of my colleagues at CHCS. So I'd encourage you to look through that, because this data is spliced and diced in a lot of different ways. As we've been talking about the different populations, again, we can see that those costs continue to change based on category of involvement with Medicaid. And one thing that we had talked about yesterday that is really important for us to get back to is the issues around racial and ethnic disparities. And again, unfortunately, this is claims data, so this does not begin to help us illuminate the issue around prevalence of a condition and access to care. Claims isn't going to help us capture that. But even once a child does get access to care, we can see that there are some populations of children who are not getting access to care as we would expect based on their numbers or their representation in the overall Medicaid program. We've been talking a lot about what is the practice, what do these children need, what do the families need? And unfortunately, the data for us as it relates to Medicaid is very concerning. In the red are what is considered evidence-based practices. These are practices that show evidence through randomized trials, through other types of practice-based research on their effectiveness. And what we can see is there's very little utilization of what is considered an evidence-based behavioral health practice in the Medicaid program. Now, certainly with coding, we know that outpatient therapy could, of course, include, say, CBT, cognitive behavioral therapy. We can assume that some type of evidence-based practice is happening over in the blue, but it certainly is not to the degree that we would want it to see. So as we think about our spend in the Medicaid system for children who have these kind of social challenges, we're not even seeing the spend where we would like to see it in the Medicaid program. We have had a panel that's focused on the delivery system of managed care. And what we know from historical data going back to the 1990s with the Healthcare Reform Tracking Project is that the data historically has shown us that children fare better in specialty behavioral health carve-outs than in integrated plans. And again, this data reinforces that that's because most children, as we've been talking about, do not have the same level of chronic conditions that adults do. And so as we look at the cost drivers in systems, we can see differences in the variation over time between fee-for-service and primary capitated models. Now, the issues that I would point out here for us is this is based on some initial 2005 data. And we do have, CHCS has also looked at 2008 and is in the process of looking at 2011. It's very important for us to be keeping in mind that advancements in managed care tools and technologies have really been artfully applied to children, and we're just now going to be, and you'll see this, you'll just beginning to see it kind of showing up in the data around kind of differences in their healthcare outcomes. So this data showed that 38% of children with a behavioral health claim also had a claim for at least one chronic medical condition. So as we think about the reverse of this number, right, so 38% had at least one chronic medical condition, we are seeing that the vast majority of children are not presenting in the Medicaid system with a chronic medical condition. Asthma tends to be the driver for that. There are, of course, children with high-cost medical conditions, but those were very low frequency. So as we look for the opportunities in the Medicaid program, they do continue to point to the behavioral health spend and the behavioral health need. We have talked about here that when services are whole population, adult and child, children tend to get lost in that discussion. We also know that from history, and again going back to the 90s, the Healthcare Reform Tracking Project and others, that when dollars are integrated, the physical health and the behavioral health spend, without special protections, say that like New Mexico, New York, and other states are doing in their Medicaid program for their capitated payments, that the behavioral health dollars get swallowed up or overtaken by the physical health needs. So the lessons learned from behavioral health that are particularly important here is how do you protect those behavioral health dollars, such as what certain states are doing with separate capitation rates? How do you think about different strategies to risk adjust for those populations so that a benefit array is designed based on an actuarially sound rate, a meaningful reimbursement rate to provide those children with the range of services that they need? There was a comment earlier, my apologies, I don't recall from whom, made a comment that patient-centered medical homes do not necessarily work as well for children as they do for adults. And there is this particular study that we often cite when we talk to governors, to Medicaid directors, to managed care purchasers about thinking about these issues around integration as it relates to behavioral health need. And what we do know, and what families will also tell us, is that all behavioral health conditions except for ADHD were associated with difficulties in accessing specialty care through those primary kind of medical home models. And the data suggests that the reason why these the services received by children and youth with behavioral health conditions are not consistent with the medical home model is really about the primary care clinician being able to connect and access with the other systems and to coordinate that care. And we've been hearing that theme throughout the 2 days. And so this suggests what we've been talking about, which is the need for very customized approaches to intensive care coordination for children, that there needs to be a specialized approach to be able to take into account that the majority of these children's needs for coordination are actually related to other systems, and they're not necessarily related to the range of physical health and medical health care that we see for certain children as well as for the adult population. So there's a range of information in this particular study. What we're seeing in terms of the trends is it's a little bit of a mixed bag when you start to compare the trend from 2005 to 2008, and again the 2011 data that's in the process of being analyzed. So during this time, there was a almost 600% increase in emergency room use for behavioral health need. There was appropriately a nearly 500% increase with access to substance use services, seeing some increase in day treatment and partial hospitalization. Unfortunately, we're also seeing an increase in residential treatment, and here this is specific to behavioral health residential treatment. Again, it's a high cost driver in a system. The outcomes are not positive for behavioral health residential care. So to continue to see it increases of significant concern for the behavioral health field. We are also seeing an increase in access to care for younger age children. So this was talked about yesterday, the need to reach children earlier in that developmental spectrum. And as we kind of think about what does this tell us about care coordination structures, and as I move into some examples from states, what this does move us towards has been the development of specific care coordination approaches to coordinate the behavioral health needs of children. And so there are about a dozen states, some of you here, Massachusetts and others, who have been implementing intensive care coordination using fidelity wraparound. And so this is an evidence-based practice that includes professional supports as well as a focus on natural supports. So at least 51% of that care plan and that team is of natural supports. All right, so here we have the focus on housing, we have the focus on success in school, we have the focus on what are the child welfare or the juvenile justice needs, as well as the primary behavioral health and, where it's applicable, those medical health issues that are beyond typical well child care visits. Two examples, I'll actually talk about three examples, but I have two slides. Two examples I'll talk about. The first is Wraparound Milwaukee, which is in Milwaukee County, Wisconsin. Here is where we see the return on investment. As we've been discussing return on investment, many of the themes around the dollars have been related to within the medical spend. But as we look at what has been successfully implemented across the country for children with behavioral health need, we see the blending and braiding from multiple child-serving systems to create one pool of dollars to meet all of those children's needs. And so the return to child welfare, to juvenile justice, to education has been very significant. And so Milwaukee County has been in operation for a long time. They get money from all of those child-serving systems, including Medicaid, to create a single point of accountability to provide care coordination for children. They're responsible for the behavioral health, the physical health, and recently they've just added dental care to their responsibilities. Through this, they also support Families United, which is the family voice, to support families in navigating the system and to ensure that parent partners or family partners, as they're called in certain states, are paid professionals and available to work directly with the families alongside behavioral health clinicians. A statewide system, as another example, is actually the state of New Jersey. Again, blending dollars from across multiple child-serving systems to create a single point of accountability using the Fidelity wraparound as their intensive care coordination. Here you also see investments in workforce and in centers of excellence to support the training knowledge that is needed across the system. So it's not just the behavioral health providers that need support to work differently as these teams. Here you see investments in all of the providers that are on the teams. The other state I'll mention, because this has come up frequently, is the state of Georgia. The state of Georgia has led real advancements in Medicaid in covering and credentialing family partners as well as youth partners. And they have really served as the gold standard, along with many other states and localities that are covering that type of support and that type of professional work in the Medicaid program. So there have been a few things then that I would highlight. As we think about return on investment, that return on investment as it relates to spend for children often is in other systems. So child welfare, as an example, is a whole system created because of unmet needs in families. Juvenile justice, again, another infrastructure created in systems. And so we have those return opportunities through our work there. As we think about our payment strategies and our delivery platforms, the other piece that I would say are lessons learned, the other aspect that's lessons learned from behavioral health, is that there is not one payment lever that's going to work. There's a lot of focus right now on population-based case rates, risk-adjusted population case rates. Those are very important advancements that we need to continue to promote to think about how we have a benefit array that's going to work for individuals. But we also know from behavioral health, as we move historically towards change systems, is that fee-for-service, which we are citing often right now as leading to overutilization, can be very helpful in uptake of new services that we want to see more of in our system. So it's not one payment lever or another that we should be thinking about. It's the intersection of how all those payment levers need to come together to create an effective system. Our care is regional, so what we may need to have be fee-for-service driven in certain parts of the country to get better uptake, such as in family and peer support, we may not need that. That may be able to be rolled into risk-adjusted population rates in other areas of our country. But again, these things work together. So with that, I'll put on my other hat, which is to facilitate question and answer.
So my name is Lisa Rosignol, and I'm from Albuquerque, New Mexico. I'm a family leader. What I kind of want to add to this discussion is sort of a historical context, right? Like, how did we get here? We got to where we are in this discussion because a mother named Julie Beckett wrote a letter to President Reagan and said that I'd like to be able to bring my medically complicated child home. And we created these community-based waivers. And we also had this other movement in the developmental disability movement in institutions that said we don't want our children to go into these institutions where the life expectancy is 18 years. So the result is where we are today, right? We've done this incredible job of deinstitutionalizing children with intellectual disabilities, or even that appeared to have disabilities, or who had unwed mothers in some cases, any number of factors, or who had technology dependence. And we made it possible impossible for them to live in the community. And we've created sort of a health crisis that we didn't really appreciate was going to happen. Because now we have 60-year-olds with autism, we have 75-year-olds with cerebral palsy, and so we have to do all this sort of management. But what's happening right now, and I feel the need to be passionate at this point, is that this population that we're talking about as boots on the ground is in crisis. Okay, because what's happening is with managed care organizations and with the Medicaid expansion and all of that, we've brought in a broader net of families that are not medically complicated and children, and that's fantastic for them. But what started to happen nationally in the MCOs is we're whittling away the family supports within these. We're seeing this especially in the 1115 waivers, where the respite now has gone from 700 hours to 100 hours. You can't do anything in a year in a 100 hours. This population that have children that are not quite medically fragile, so they wouldn't qualify for our 1950 waiver. They don't have an intellectual disability, and so they're going into the 1115 waiver. And so they're losing these community supports, and so what's happening is they're in crisis. And so we're having families that are making the decision to re-institutionalize their children because they can either expedite them onto a 1915 waiver or because they don't have the resources. We used to have a community direct support that went away with 1115 so that families got paid a pittance, really, but it was a thing that could keep them floating. And so they're having to go back to work but not having the respite because personal care does not cover you to go to work. So this population, we are in this expansion and bringing more people into the fold. We've created a crisis for this population that can't qualify for Medicaid through SSI or income support or those other ways, and they can't find the appropriate child care for them. And so we're really kind of going backwards in a lot of ways. And so when we're thinking about this policy, I think it's really important to understand that for those of us that are living this, this is actually, and return on investment and all this sort of stuff, it's scary, it's awful, and I think that we need to be freaked out about this. I really think that practitioners need to understand that we need to be really freaked out about how backwards we're going and the lives that we're endangering with this.
Hi, I'm Elizabeth Frio.
So the comment I would have is that I completely agree. Part of the biggest challenge we have is how do you solve for issues? Respite's a great example of that, where we can't get paid for respite, but we often offer it because it's the right thing to do, because without respite, you're going to have an emergency room visit that was unintended and unnecessary, quite frankly. And so making the investment at the right place at the right time is logical. Unfortunately, it doesn't always fit with how programs are designed. I think we're seeing more and more sensitivity around natural supports and payment for natural supports and peers and other non-medicalized reimbursement, but the system is lagging pretty substantially in terms of how do you capture those costs, how do you make sure that there's no fraud and abuse in those services, because that's, people are freaked out by if you pay the family, it's going to be a terrible thing, right? And so the reality is I think we're in a lag. I would say most managed care organizations that are caring for complex populations are making the bet that it will eventually catch up. And so we're tracking where those investments are being made, and we're hopeful that at some point the rate methodology will catch up. It doesn't necessarily work today. So I think you're right. I think it's a scary time. And what we've seen in certain markets are that there is suddenly there is reinstitutionalization happening, particularly states that have been very aggressive in deinstitutionalizing without the natural supports and the other services around it.
The piece I would add to it is that where we have seen coverage of respite, it has come from those other system dollars. So it has come from the child welfare diversion, from the 4E dollars in child welfare. It's come from juvenile justice. It's come from education. It's come from the maternal and child health block grant. So that's why, I think, again, those lessons learned from behavioral health, which I know are just a piece of what you're raising and talking about, they've had to go to those other systems to get those dollars. It'd be a very interesting discussion to talk about the Medicaidation, how would you say that? Making Medicaid cover respite. And kind of, we know that that's the #1 service parents want. That's what they ask for. That's what they need. And so, I do appreciate that you raised it as kind of that alarm call for us to be continuing to focus on that. And so now I will turn to Elizabeth.
Hi, I'm Elizabeth with the National Disability Rights Network. And I'm really going to echo what was just said along a different line. That again could force kids into institutions as opposed to appropriate community-based services. But I represent a nationwide network of disability rights programs in every state, and they often will take cases on behalf of kids who receive EPSDT, the Children's Medicaid Program. And as we heard on the first day, the speaker was talking about policy, said she wished she could tattoo on every pediatrician's arm that EPSDT provides a different standard of medical necessity, that they have to cover not just a medical necessity to correct, but to correct or ameliorate. And this is one of the things that we're seeing when you have more of these commercial plans that are not used to serving the long-term care, the complex care populations. They're not familiar with EPSDT screens, and they're not being told by managed care programs, look, when you are serving the Medicaid population, you have an entirely different set of screening tools, you have a different medical necessity standard, and I know that this is being tried, but we are just seeing across the country that EPSDT is not being followed. And a second thing I wanted to say was just to note Suzanne's presentation. She said some of the best practices that we found in our report, I guess this was at University of Maryland, and you talked about how specialty carve-outs were, the way to go, and how when you're going into managed care programs, it's important to have special protections for children with complex care needs. And yet what we are seeing, and what you also said in your report, was that states were rushing to managed care programs and increasingly going to global waivers. So that's the exact opposite of what we would hope, because the global waiver being proposed, say, I won't pick on a state, where they'll say, now, instead of having a separate TBI waiver, where we had programs that were specialized to folks that had neurological disabilities, that are not the types of disabilities, are not the types of services that the general population needs. They had these small, in other words, carve-out programs for where you could go to if you needed a high level of respite, higher than the general population. And now as states are developing these global waivers, we're not seeing the special carve-out AIDS program, the special carve-out TBI program. And also because they are rushing, we're not seeing the special protections being put in place. And I'm sure all of us here say it, but I just wanted to have it on record that the programs you mentioned in Milwaukee and the wraparound services, those are great, but there's still a rush in the opposite direction as well.
Yeah, a few comments I would offer, Elizabeth, to that is that First, I would say, based on my work here in the country with various Medicaid purchasers, managed care, as it relates to behavioral health, is that we see great examples on the integrated care side for kids with behavioral health needs, and we see bad examples on the integrated side. We also see great examples on the carve-out side, and we see not so great examples on the carve-out side. So I think one of the pieces that we want to do is move away from an either-or discussion, but go back to that concept of what are the levers, what are you trying to do, and what does your system already have to work with? So we have a lot of success with, say, what Chris has done with having a whole population taking care of all of those needs in one plan. We have a lot of success, say, from Massachusetts that has integrated and carve-out plans side by side, doing different things for different populations. We have the example that I showed up of Wraparound Milwaukee, which is a managed care plan. It is a managed care plan, but it was designed to do something specific for a specific population. So I would encourage that our discussion is not an either-or, but it's a what are you trying to do in that system, that state or that region? What do you already have to work with? What are those goals? Because then those managed care tools in their technologies, you can use them as levers to support where you want to go. And so I think as you look at the body of knowledge as it relates to managed care, that's what that would point to. Complicates the picture, but it gives us so many more opportunities.
Okay. Dennis Quove, Arkansas. This question is more directed towards Chris Bourne, but I think anyone can answer this question. I'm struck by the need to hire 200 service coordinators in a very short period of time. Having personally been involved with hiring and training of care coordinators, it takes a while to get folks up to speed. So I was wondering about the thoughts of workforce analysis to try to develop these models, as well as some of the themes that were discussed earlier in the symposium about whether we are duplicating services and whether we can leverage other folks who are already using these services.
So I'll be very specific. The state, Texas Health and Human Services Commission, has come up with criteria that requires probably a significant investment in care coordination in the home. And so they've come up with a tiering system that puts children with the most significant medical complexities in a tier 1, moderate in tier 2, and low in tier 3. And the requirement is that there be 4 in-home visits per year for the 1, 2 in-home visits per year for 2, and then 1 with follow-up telephonic calls for the group 3. And that is primarily to do the survey assessment instrument, which documents all their need for personal care assistance, supporting activities of daily life. There's the documentation for the durable medical equipment, the private duty nursing, etc. There's that development of the individualized service plan, and then there's the execution. The math is the math, and how long it takes to do that. You can do possibly 4 visits with a care coordinator per day, and then you do the math of how many you think are going to be in the tiers and how many children you're going to serve. So it just becomes a math equation on how many you need. Where they're located, I think, is a critical decision for us. We need them based in the communities where the children live, and we aren't looking at a centralized, they're all going to be in the office on the phone. I mean, to the extent that we can, those supported practices, we can put care management in their offices, we'll do that. In the communities, we'll do that too, and if it needs to be in a centralized area, we'll do that. But it is a heavy, heavy lift.
And what's important is while he's recruiting 200, so are we in the same service areas. And so, so that's one of the challenges, and I think the state of Texas was pretty prescriptive in the contract design that required, there's a lot of prescription in who we can hire, how often they have to do it, et cetera. Not every state is that prescriptive. So to your point, there are other states' programs that have a bit more flexibility in terms of contractual requirements that afford us the opportunity to leverage other resources like community resources, like resources in providers' offices or in other offices or in community-based organizations that can help with some of that. That doesn't, though, in our opinion, supplant the comprehensive model that we then have to augment. So even when we do that, there's some staffing requirements that we have to put in place, but it's not the same as what the state of Texas has required in their design.
Thank you. Carolyn.
Hi, Carolyn Langer from Massachusetts. Thank you. I enjoyed all three of your presentations. My question touches on some of the issues that Elizabeth raised. I'm just going to ask my question more broadly. Maybe I'll direct it to you first, Catherine, but Chris, you touched on some of these issues, but please feel free to add additional information. You both mentioned Medicaid managed care. Catherine, I'm wondering if United has entered into capitated arrangements or at-risk arrangements with any providers, particularly around children with complex health care needs. This is a real paradigm shift, especially if they're being asked to take on behavioral health integration and long-term services and supports. So I'm wondering if you have entered into those arrangements, how have you prepared these practices to take on those functions which have traditionally not been within their skill set? And if you have not entered into those arrangements, if you're managing that all in-house, you mentioned building up expertise internally in these different areas. What are you doing internally to ensure that those three functions, the medical care, the behavioral health, and the LTSS management, are not all acting in silos within your organization, but coordinating to really develop the best care plan and benefit package for your members?
So to the first question, we have negotiated certain full capitated relationships. They are not unique to a specific population at this point in time. However, we are in the process of negotiating a contract with the children's system in a state to be fully capitated on our behalf for complex kids. What's more common, though, is that we're working with providers along a continuum, and if we use capitation as the stopping point of that continuum of looking at how do we create incentive models to improve care and focus on value. But we don't think providers do that on their own. So we have a variety of resources that we bring into practices to support them, and it ranges from practice transformation specialists who can think about data, who know how to help practices think about integrated care, but it also could include that we actually take a behavioral health specialist and we plant them in that practice, and that individual becomes a member of that team even though they have a payroll that's on our side. So there's several things that we're doing in terms of people, process, data, to help providers move along a continuum. Each market is so very unique, and the capabilities even within a given state. So that example of the negotiation that we're in process now is a tiny sliver of the entire state, and so it's only going to solve for problems in one geography. So we have to develop different approaches in different parts of the state, or in all of our markets. To the second question, we actually don't think about them in silos. So all of our care is delivered in an integrated fashion, assuming that the benefits are integrated. So if we have a carve out of behavioral health, it's a little different. We're jumping over to whatever the behavioral health delivery system is. But in an integrated system, we are actually, it is fully integrated. So it is a care manager who's thinking about physical health, behavioral health, social supports, all of those things together in a single plan of care. And so we develop expertise because I happen to be a policy geek, but I have a bunch of colleagues that are behavioral health policy geeks, and we work together. It's the same kind of thing that we have certain levels of expertise that we bring together, but at the end of the day, it's one plan of care, it's one comprehensive assessment, and it's all managed through an interdisciplinary care team. Sorry, it's a long day.
I would like to say that we don't use any type of capitation with our primary care physicians in the Southeast Texas area because there's just not enough squeeze in the Medicaid fee-for-service rates that we're required to use as a minimum. What we find better is incentive-based compensation that rewards the types of things that the state is relying on managed care organizations to do. So right now, 4% of our premiums are withheld or the potential of doing a clawback if we don't meet certain minimum standards when it comes to the HEDIS performance measures, whether it's well child visits or it's prenatal visits or postpartum visits. And then we're also held to a very high standard on potentially preventable ER visits, admissions, and readmissions. So a lot of our incentive programs are really focused on what the state wants us to do, and then we drive that through a reward program. So it's not unusual for us to reward specific high-performing physicians up to $20,000 a quarter if they meet certain achievements. And $20,000 a quarter from one health plan or $80,000 a year is significant to move results. The other thing is we don't do anything in the health plan from a care management perspective that segregates the medical from the behavioral health. So we're all team-based care, and we have on our care teams, we have licensed clinical social workers, psychologists, as well as RNs and APRNs. We have an obstetrician as a chief medical officer. We have a pediatrician as a chief medical officer. We have a doctor who specializes in high needs children as a medical director, and a child psychiatrist. So we have a really robust team of medical leadership that's doing the oversight of the quality improvement plan and the care development planning.
We have about 7 minutes left, and we do have 4 additional individuals wanting to offer comments, so let's move.
Thank you. Richard Pan from California. Since I have to vote on the state budget every year, one of the questions, I noticed that in the data was presented from the Texas Children's Health Plan that clearly the biggest variation is coming from the most expensive patients. I don't know if that's a cohort of patients you're following, or is that just the top 10% for each year? But that level of variation is actually larger than the total amount you're spending on like the lower, 40-50% of the patients. So, and I know you just mentioned HEDIS measures, but those are usually around primary care or actually not children with complex healthcare needs, because those are a small population. So I guess the question is that, state tries to capitate, right? But you're having to deal with this variation from year to year. Does that make sense to do for a state to capitate a plan where basically what happens is that amount of variation, which may not be controllable from your perspective, totally controllable, then creates a disincentive to then invest in all the stuff that we talked about here. You're going to try to do it because it's the right thing, but financially the problem is you have a down year. If you get a fixed capitation rate, even if you can negotiate some increase up, what happens is how do you manage that, and should therefore policy-wise we be requiring that actually, we always talk about shared savings, but there does need to be some kind of reinsurance or something so that you don't take the full hit for the variation, and that we can consistently be sure that the resources are there to continue those investments and the care coordination, all the other stuff. And then second to that is, I don't know how long your contracts are. Of course, we do a budget every year, but we talked here about relationships, right? And I mean, we have a health plan representative. How often, is there something to be said about, well, what happens if you contract with one group 1 year, or even for 2 or 3 years, and you contract with another group? Suddenly you take all these kids, and you have to start all over again because you have a whole brand new set. Maybe there's some overlapping providers, but our whole new set of care coordinators, by the way, the ones you hired. Hopefully you can hire and block from the previous plan to the next one, but my guess is that isn't what happens. So then now what happens, the families have to start all over again, going back through all their histories and so forth, and what's the cost of that to care as well? So, comments?
Let me first of all take that 10%, that was a consistent cohort throughout those 3 to 4 years. So the way that I was looking at it is very opportunistically, and I think that's a population that I can engage the system in helping solve. Like in some of those children, we had ventilator-dependent children, or with a trach and a G-tube. And what was happening is we were studying those particular patients is there was a tremendous level of failure where they'd be in the hospital in the progressive care unit for about 30 days, and then they'd be home for 6 days, and they'd have a failure, and they were readmitted. So having that technology-dependent program where the system thinks about how to manage care with the ability to do a better job at the front end of the stay, so that when they're successfully placed in the home, they're managed correctly, right? And does that mean doing sending a respiratory therapist to do the home visit? Does that mean sending, if we have an upper respiratory infection or a urinary tract infection, can we start a home therapy of an IV antibiotic? I think what the typical system, the way it's set up in a fee-for-service, is they're gonna call maybe their primary care physician, and the primary care physician is gonna go to the emergency room, and then they're admitted for 7 days, and that's nuts. So it's like it's transformational. It's like there's a whole new level of engagement with the system that says we can do a better job.
So I guess the question is, what percentage of that variance is what you're talking about that you can reduce, and what percentage of variance is
variance? So go ahead.
No.
That's an important question because
We have about a minute remaining.
So, in the very brief time, the answer to your first question was actually your second part of the question. So we see these as multi-year relationships. So we don't actually look at it in 1 year where we may have a catastrophic year. Where we are an insurance company, every insurance company can have a catastrophic year regardless of whether it's property and casualty or healthcare. And so we look at it over a multi-year relationship, and what does that look like? Most times when there are big swings, there are opportunities for us to actually go in and improve the outcomes. And so we don't see it as something that we cut and run because it was a really crazy year. It's about what could we have done to impact those kids or those members to have impact longitudinally.
Apologies, but we are signaled that it is time to stop. So we apologize we could not get to all questions. Thank you very much for the discussion following this panel. And we'll turn it back to Ed.
Well, I want to thank the panels and all the panels. Thank all of you for attending. This was the value of this came as much from the comments and discussions, both the formal ones here and the ones out in the hallway, as much as the panels themselves. So when you were all invited, it was invited as participants, and you all participated, and that really contributed to the success of this. I need to thank again the National Academy of Sciences staff for keeping this really smooth, and everything went well. That was really nice. As well as to Olivia, who really kept this going. And I guess finally I need to remind you that that David and I and Olivia and Holly work for a foundation, which means we're interested in ideas and proposals to advance this field. We're also interested in if you have some ideas for follow-up, continuation, continuing this discussion, taking up pieces and moving it into other arenas. I think there's a lot here. We'd like to see this as a springboard for other things, and are really open to suggestions from any and all of you about that.